Okay, I think we'll get started, and if we have some people dialing in just a minute or two, we won't miss too much on that. So what I wanted to do with this presentation around acute hepatitis B is just go over, um, the cases with or the disease with the perspective of looking at kind of what are some of the things that maybe aren't emphasized that much in the guidelines with DOH, and maybe throw some things in there that might prove useful for some people. So let's get started. So here's kind of an outline of what we're going to be talking about today. We're just going to do an overview of hepatitis B in terms of some of the clinical aspects of it. We're going to talk about the labs because sometimes there's a lot of confusion with those because there's a variety of different labs for this. We'll touch base on a few problem situations that come up rarely. We'll talk about case management and then go through 3 case studies of cases where the names have been changed quite a bit, but the situations are comparable to what we've seen here and in other counties. And then we'll talk about some more complex situations where I call phone a friend, where we really need to be involving DOH or other partners with. So let's kind of get started with that. If we're looking at kind of the big picture overview of hepatitis B, I want to go over a little bit of the epidemiology first. You can see, almost 1 million to 1.5 million people are chronically infected with hepatitis B, but we see a small number of acute cases that are reported nationally, only 3,200 in 2016. And they always estimate that up, based on people who are asymptomatic or whatnot. But 1 case per 100,000. If we're looking at Spokane County for us, that's 4 to 5 cases per year. Sometimes we're at that. I'll talk about this a little bit later. This last week we've had 3 cases diagnosed, in a little cluster. So sometimes it goes up a little bit more than that. So the other thing that I want you to kind of look at, mainly our transmission with this is going to be through blood or sexual contact, where we're not really worried about other bodily fluids like urine or stool or breastfeeding so much, but we're really focused on blood or sexual contact and looking at that. The key critical piece in terms of acute infection, where we look at age, is the likelihood of progressing to chronic hepatitis B. So the younger you are, the more likely you are to be chronically infected after an acute infection. We see this with newborns, almost 90%. This is why we have the perinatal hepatitis B program. Even older infants and toddlers, 30 to 50% of those are going to progress to chronic infection, while with adults it's usually only in 5 to 10% will progress to chronic infection. So let's take a look at looking at some signs and symptoms with this. The big thing I want to emphasize here is that even though the cases that we see are very symptomatic, they're jaundice, they have a lot of symptoms that bring them usually into a hospital or to the clinic to be seen, quite a substantial number, 30 to 50% of people who are older, adolescents or above, are symptomatic. So the majority of people are ones that are asymptomatic or mildly symptomatic, and these can be really tricky in terms of identifying. The symptoms that we see with acute hepatitis B are comparable to other types of viral hepatitis. You really can't distinguish between A, B, or C based on symptoms. There's going to be a component of GI symptoms, nausea, vomiting, diarrhea, abdominal pain, loss of appetite, weight loss. Oftentimes, the most predominant symptom that we see is abdominal pain and loss of appetite in terms of the GI symptoms. We see a lot of fatigue, joint pain, very little fever that I've seen. Some itching, which is more of a referred issue for liver issues. And then we'll see some, hopefully some evidence of jaundice, whether that's dark urine, skin that's turning a little yellow, the eyes turning a little yellow, clay-colored stools. All of those are evidence of acute hepatitis processes. So symptoms, generally several weeks. I've seen them up to 6 to 8 weeks. I haven't seen anything, as long as several months, but certainly that's in the literature. So let's take a look here. I've just got some pictures of jaundice, so you can kind of see some things are going to be very evident, where we have yellow skin, yellow eyes. This level of jaundice probably in a bilirubin, 15 or over. Where sometimes, as you can see over here, it could be a little subtler, where you may just see a little yellowing of the eyes. When I put this slide in, this is from the DOH guidelines, and I just put this from the perspective of the case definition for acute hepatitis B. We look at a clinical component with, requiring a discrete onset of symptoms, and then any of those that we talked about earlier, and then either jaundice or elevated ALTs. So the clinical criteria is where we can get stuck at times in terms of meeting what's needed for the case definition for an acute hepatitis B. Because remember, we have a significant portion of people with acute hepatitis B that are asymptomatic, who aren't going to meet this criteria of having a discrete onset. And unless you have some documented negative hepatitis B labs, 6 months or less, we're not going to be able to define those as acute cases, or not easily. So let's take a look at some of the labs around hepatitis B. It's kind of a mess, and then you can see it here. It can be a real challenge with interpreting hepatitis B labs. What I did here on this slide is I'm in my mind, when I look at hepatitis B labs, I try to associate each lab with 1 or 2 words in terms of what that tells me about the individual. So hepatitis B surface antigen here, this is evidence of infection or vaccination, because the surface antigen is the active component in the vaccine. Surface antibody here, evidence of immunity. Core antibody total, you're only going to have this with a natural infection. This isn't a consequence to vaccine. The only way you're going to get a core total that's positive is if you have a natural infection of some sort. Core antibody IgM here is the marker that we have for acute infection. That's usually present, during the first 6 or 7 months after infection. E antigen and E antibody here, to me, they're measures of viral replication. So if someone is E antigen positive, that means they have an active infection. A lot of virus replicating, usually acute process, but you can see this in chronic disease. E antibody as a measure of a dormant infection. So if they have an E antibody positive, we can say that they've had hepatitis B, but there's not a lot of viral replication happening right now. You'll see some hepatitis B DNA tests coming up in FRED or in WDRS. These are mostly used for medication management decisions and aren't as useful for us on the public health side of the equation. Hepatitis B genotyping, often done with a specialist, again, useful for medication management, but it can be useful for us in terms of outbreak investigation, because we can use genotyping to get a sense of if 2 cases are related in terms of having the same strain of hepatitis B. So, I like to look at all these and just, those 1 or 2 words to kind of figure out what I've got when I get a lab report. Let's take a look at a couple of examples with this. First, before we do those examples, let's take a look at kind of the natural history of these lab markers for hepatitis B. So starting here based on weeks after exposure, you're going to see a rise of surface antigen. That's going to drop off. Core total is going to be with you the rest of your life. It's a very persistent antibody where the IgM will drop off over time as a person resolves their acute infection. You're also going to see kind of in this broad area right over here, we have the period of time where someone's symptomatic. But there's a couple of inflection points, right around here, where someone can have surface antigen, but maybe not core antibody IgM yet, or core total. And then there's some inflection points over here that can change a little bit, that make it a challenge to interpret. So let's take a look at a couple of examples, like I said. Before my example, I've got one more slide or two looking at liver function tests. Now, these can be a little bit of a problem in terms of interpreting because they can support your diagnosis of acute hepatitis B, but there's a lot of things that can cause elevated liver function tests. And so primarily we're looking at ALT, but if you see AST as greater than ALT, usually by a 2-to-1 ratio, if it's that high of a ratio, then that's usually not viral hepatitis in most cases. Usually that is more seen with alcoholic hepatitis. So that can be a little confusing because oftentimes people who have substance abuse issues might have alcohol abuse issues as well. The other point here, there are some non-hepatic sources of ALT that could cause some confusion, skeletal muscle, cardiac muscle, kidneys. So if you have someone who's being admitted to the hospital, but maybe they have an MI or a heart attack, or they have a crush injury in terms of muscles or rhabdomyolysis, you're going to see a spike in terms of their ALT that may not be representative of acute infection. It could be that they have a chronic hepatitis B infection, but they have some of these other issues that could explain their elevated transaminases. I'll put this in here also because a lot of times when we see elevated bilirubin, that's usually when we're seeing gallbladder issues. And if we can rule some of these things out by looking at their alkaline phosphatase, if that's greater than their ALT value, then that's suggestive of gallbladder problems. Again, these are just some clinical pearls that may or may not be helpful, but they're going to be able to provide a little bit more of a way to kind of measure the context of what's happening with their liver function test. I put in here some typical ranges, that we often see. Normal range is under 45. We will see stuff that's in the 45 to 120. Remember, on the case definition, they want to see anything above 100, but you can see lab values in the 80 to 100 range with chronic hepatitis B, with someone who has cirrhosis or something like that. So, there's a lot of potential explanations for an ALT elevation in this range. In the 300 to 500 range, somewhere in that range, you can have some other issues that can cause problems in terms of distinguishing between viral hepatitis and some other liver pathology. I like the 1,000 to 5,000 range. That's a kind of a sweet spot. Most of your gallbladder and other issues aren't going to have elevations this high. And this is very compatible with acute hepatitis, acute viral hepatitis, I should say. Could be other things as well. If you're getting really elevated numbers over 7,500, I'm thinking something else is contributing to that as well. Usually we're seeing liver failure with that. We may see drug toxicity like in an overdose. We may see hepatitis D co-infection with hepatitis B. Something's causing that that person to go into liver failure. So, those are some quick rules of thumb. So now we have our first quiz in terms of looking at our labs. So what we have here is a surface antigen positive. We also have surface antibody positive. And we have core antibody total that's negative. So I'll show you, I kind of use those words and try to form it into a sentence. This is how I think about it in my mind. So here we have someone with evidence of infection or vaccination who is also immune and who has no evidence of natural infection. So if someone's not had natural infection, also immune, we're thinking, wow, this person, this might be a vaccination issue. And so indeed, this is a common situation. So here, this would be an example of someone who tested positive for hepatitis B. And the context of where we see this, and believe it or not, this actually comes up fairly frequently, is when someone's referred to dialysis. Part of the intake process for that is that they get screened for hepatitis B to see what their status is. And sometimes someone who's moving into dialysis, maybe their primary care provider starts them up on the hepatitis B vaccine. They start that vaccine, they go into dialysis as part of their intake, they get screened and come back positive because that hepatitis B surface antigen is actually a component of the vaccine. So even though they're immune, maybe they're 1 or 2 shots into the series, and we get this type of false positive result in terms of looking at a potential hepatitis B infection. So let's take a look at another one. We have another quick quiz here. We have surface antigen positive. We have a core antibody IgM negative, and we have a really high ALT. So we have some kind of acute process going here. If we phrase this into a sentence, we have someone with evidence of infection or recent vaccination. They don't have any evidence of acute hepatitis B, but there's also evidence of acute liver injury with those elevated transaminases. So I'm going to take a look at the labs again. And in this spot over here, this little transition zone, we could have someone who's here. Let's say they get tested here. They have surface antigen. They have no core antibody total or IgM, and they're in the acute phase of the illness. So this is a potential thing that we need to rule out. So how do we rule that out? We're going to ask the provider to add some additional labs. And we added a hepatitis E antigen. Remember, this is our measure of active infection, and we measured a hepatitis B DNA. So the E antigen came back negative, so we don't have an active infection, and we have a very low DNA. Now, if we went back, we would expect high DNA here. We're in the replication phase, and we would expect this to be E antigen positive. So what we're looking at here is someone who has evidence of infection, not acute, is dormant, but they also have evidence of an acute liver injury. So this could be someone who just has a chronic infection, but went to the hospital because they have some other acute liver injury, whether that's a suicide attempt, like with an overdose, or traumatic injury to the liver, something else that's causing high transaminases or liver failure. So those are some quick examples in terms of how to interpret the labs for these conditions. So now I want to talk about some problem situations that sometimes come up and can be kind of tricky in terms of taking a look at. The first one that I want to look at is hepatitis B reactivation. And so with someone who gets a hepatitis B infection, they usually fight that off, but you're still going to have some virus that's dormant in the DNA of a patient, and that can reactivate, when there's usually some immunosuppression, with the patient. So sometimes that can be with cancer. They're taking immunosuppressive medication, maybe for rheumatoid arthritis or something like that. Sometimes you can see this happen with HIV medication because some of the HIV meds also suppress hepatitis B, and if they happen to switch to a new HIV med that doesn't have an effect on hepatitis B, you can see a reactivation there. People who are post-transplant or getting a transplant can see that, or people co-infected with hepatitis C. So what will happen with this is you'll have a case who looks to be chronically infected. They have a long history of hepatitis B, maybe, and then now all of a sudden they're IgM positive. They've got transaminases in the 1 to 2,000 range. They're symptomatic, and for all purposes that they look like an acute hepatitis B case, and we're going to treat them like an acute hepatitis B case from the point of view partner management or managing them as a case. I've only seen this once, and it was kind of a older adolescent. I think he was 17 or 18. He was picked up hepatitis B from his mom at birth, so he was a perinatal case that the vaccine wasn't given at the right time or whatnot. So he was chronically infected, and he had a childhood leukemia, I think, that came up, and that's what put him into a flare. And he looked just like an acute hepatitis B case, but we had plenty of documentation from his numerous GI visits that he was being managed as a chronic infection prior to that. So let's take a look at another situation that can cause some confusion, and this is with a persistent IgM antibody. And this can be seen in about 6% of patients who have an acute infection. Normally we see that IgM antibody fades and becomes undetectable within 6 to 8 months. But this is with someone whose IgM antibody will persist over time, maybe for several years or decades even. So these can be a little bit tough to figure out because they cause a lot of confusion. If you have prior documentation where someone was IgM positive more than 6 months ago, that can do it. But otherwise, if you don't, we look at usually ordering an E antigen and a hepatitis B DNA because we would expect to see some measure of active viral replication. Sometimes you'll see a surface antigen that will be positive in this situation where someone's chronically infected. So we really look at that E antigen as being important to look at that acute phase. And I've got an article here where you can take a look at that if you wanted to read up on that a little bit more. I put this in there as well because hepatitis B forces us as public health to really look at things that are reportable versus things that are actionable, because you're gonna come up with cases that don't meet the case definition for reporting purposes, but based on their labs and their history, from a clinical perspective, you would think that they had acute hepatitis B, and that you would want to manage them from that perspective in terms of at least advising them on next steps for protecting their health, but also from the point of view of partner management. The situations where this comes up most frequently is we don't meet the clinical case definition. Maybe, someone has other medical conditions that have or medications that mimic some of the side effects or mimic some of the symptoms that we would see with acute hepatitis B, and you're really not sure where those symptoms are coming from. We'll sometimes see this with people who are going through drug treatment, and they're going off of heroin or something like that. They're going to be symptomatic in some respect, but you're not really sure where that's coming from. You're also going to see that with some people who just aren't jaundiced and no LFTs were done. Maybe they just had a screening test that was done. Maybe this was through a situation where they're just going through primary care, urgent care, and they're homeless, and then they don't go back in, or you can't do anything with that. If it's just a question of no LFTs being done, oftentimes the labs will hold specimens, hold serum for up to 2 weeks, and you can oftentimes talk that doctor into adding a complete metabolic panel on to see if that will provide any support for that case definition. But again, there's sometimes where we don't necessarily get to the point where something is reportable. So, and I want to talk a little bit about case management. I mean, it's pretty basic with acute hepatitis B, very similar with A. We're going to want to talk with someone who's acutely ill about getting retested in 6 months. We cannot tell based on someone being their symptom status at 6 months whether they are in the lucky 90% who fight off the infection and become immune, or the unlucky 5 to 10% who go into chronic infection. So we want to really encourage everyone to get retested in 6 months. We do want to recommend prophylaxis for contacts as appropriate. So usually household contacts, we're just recommending vaccine. But if you have a sexual partner or someone who had a direct blood exposure or they're needle sharing, those people we would recommend vaccine as well as hepatitis B immune globulin. And we also want to educate the patient about how to reduce the risk of transmission, what they need to do in terms of either using a condom, or if their partner is fully vaccinated, things like that, they can help. And we also want to use this as an opportunity to recommend hepatitis A vaccination for them. Especially if we're dealing with folks who are maybe homeless, or who have significant risk potentially for hepatitis A. If we look at post-exposure prophylaxis with hepatitis B immune globulin, this isn't the easiest thing to always get done with patients. We want to do this as early as possible, but it becomes a challenge. At least we've had challenges here in Spokane with this. This is, again, only recommended for sexual contacts or direct blood exposure. For us, it's only available in hospital emergency departments, anywhere that does maternity, because your source of hepatitis B immune globulin are those hospital pharmacies who use this for perinatal case management, with babies born to hepatitis B positive mothers. But our problem here is that providers often want to test the contact prior to giving the hepatitis B immune globulin because of the cost. So that usually equates to 2 visits where they have to come back again. And in some of our contacts, we've had struggles with getting them back in an appropriate time frame. So, but it is what we would recommend for anyone with a blood contact or sexual exposure with the case. So this is our first case, and I've changed the names on this. This is Betty. She was diagnosed with an acute case of hepatitis B at the emergency department, St. So-and-so Hospital, and she had the following labs in presentation. So she was positive for hepatitis B surface antigen, positive for core antibody IgM, so definitely looks like hepatitis B. ALT in the 5,200 range, definitely there. You can see that the ratio is not greater AST than ALT, and total bilirubin of 11.6, so she's a good shade of yellow. She presents with that onset of fatigue, yellowing of the eyes, dark urine, joint pain, loss of appetite. But Betty has a pretty complicated history from the perspective of risk factors. She uses both meth and heroin, but says she does not share any needles. She was incarcerated for 10 days in the county jail, 4 months ago, so within the incubation period for this. She's bisexual, but has a steady same-sex partner for the last 4 months, I should say. And she's had 2 dental extractions in the last 6 months at a community clinic. So a lot of potential risk factors here. Certainly some of the substance abuse ones, are a little bit stronger, in a sense of risk. So we move forward, and she brings up a lot of questions because the reliability of her history, there's a lot of things that may not be said. Did she really never share needles? Or could there have been times where she would have slipped up? would she have used while she was incarcerated? Would she disclose that to us? A lot of times after someone's released from jail, they don't have their equipment. That's probably even if they're fairly safe, this might be a time where they use someone else's equipment until they get something of their own. So it's an opportunity for sharing. And are there any sex partners she wouldn't disclose because they might be people she uses with, or potentially a dealer, and she doesn't want us contacting them? So tough interviews with these. And she only disclosed one sex partner, and that was Bonnie, her current partner of 4 months. Bonnie has no history of hepatitis B or hepatitis B vaccination. And we begin the process with her because she's the only one disclosed in terms of arranging her prophy, which starts with testing her for hepatitis B. So we take a look at this, and we get the following report from the lab on Bonnie. She's positive for hepatitis B surface antigen, and she has an ALT of 28. First blush, when I see something like that, I'm thinking this could be a chronic carrier. Maybe this is a source of Betty's infection. Maybe she didn't realize that, her partner was a chronic carrier. So now things change a little. She has a new risk factor. Betty has a new risk factor in the sense of her relationship with Bonnie. There may have been some needle use between them or sharing. Certainly, even though Bonnie didn't have a history of hepatitis B, she was also positive for hepatitis C, so she had some high-risk behavior in the past. And, so this may be our smoking gun in terms of looking at a risk factor. Certainly, someone who's a sex partner of a chronic carrier, also potentially sharing needles, also household contact. She does kind of move a little bit to the top of our list for that. But then things come crashing down for us. 8 days after, we find out about Bonnie, we get some new labs for her. And these labs show us a different picture. Now Bonnie is looking like an acute case. She's surface antigen positive. She's core antibody IgM positive. And now she has an ALT of almost 2,000. So what happened here? What happened is, we tested Bonnie at potentially the earliest stage of her infection prior to that increase in viremia. This is going to be that stage just where the surface antigen is going up, but before we get the IgM antibody and before the liver transaminases. So this was almost a perfect storm in terms of trying to, within days, she would have probably been in this couple hundred range in terms of her liver function tests. The problem that we made, or that I made in this situation, because this was one of my patients, is we made the assumption that we wanted to, because this was the easy case. This was the smoking gun, like I said, and we could tie this case up because we knew exactly where she got it. We should have followed up with the initial lab by adding a core antibody IgM to really confirm that Bonnie was a chronic carrier, rather than catching this at the early stage that we did. And we need to do this because even though Bonnie didn't have any symptoms at that time, a large percentage of our acute hepatitis B cases are asymptomatic, so we need to take that into account. So in the end, we know that Bonnie was not the source of Betty's infection, but likely acquired it from Betty herself. And we still don't know exactly where Betty caught the infection. So this is our first case, kind of looking at just those issues that come up when we're trying to figure out the cause of these infections. We're going to go to case number 2 at this stage. And case number 2 is something I kind of borrowed a little bit from Northeast Tri-County. We'll change things around a little bit. But this was the case of the complicated co-infection, because this was, again, another report from St. So-and-so Hospital, where James B., who was diagnosed with both hepatitis A and hepatitis B, and he had the following labs and presentation. So he was surface antigen negative. He was core antibody IgM positive, so marker for acute infection. Antibody IgM positive for hepatitis A, so marker for that. He had an ALT that's certainly suggestive and a ratio that suggests viral hepatitis. And he has compatible symptoms, in terms of GI symptoms, fatigue, nausea, vomiting, jaundice. But he has a pretty mellow history. He had no travel in the last 9 months, so we haven't had any hepatitis A here, so that's good. He has a job as a musician in the symphony and does not drink. So he denies any substance abuse, and states that he's monogamous and has the same partner for 12 years. So not a lot of risk factors here for hepatitis B, and no travel, so not a lot of risk factors for hepatitis A. So a little bit of a puzzle here. So when we follow this case down, not a lot of clear risk factors, like I said. So in a situation like this, the best thing that we can do is to try to add some more labs. Additional labs are going to be able to provide us some other answers on this. But we'll figure out what labs we want to do in just a sec. The other thing we note with him is that he is tested negative for hepatitis A or B, 3 years ago, so no history at that time. No gallbladder issues, never been vaccinated for A or B either. So he could put himself in a position where, he could still have either one of these. There are no other labs that we can recommend for hepatitis A for James, but there are some that we could recommend for B, because we want to look at, right now that surface antigen is pointing to no infection, the IgM is pointing to an infection, so we want to add some additional labs. So what would we do? We would probably look at doing some additional testing around E antigen and hepatitis B DNA. Because again, DNA probably going to be low in a chronic infection, probably going to be high in an acute infection. E antigen should be positive in acute infection. There are times with chronic infection that can be positive too. But we've got to start somewhere, so we're going to try adding these labs with this. And here are the results. If we look at those, E antigen negative and hepatitis B DNA non-detectable. So right now, both of these being E antigen negative and DNA non-detectable, that supports the surface antigen negative. Because both of these are showing no infection or no virus present. Is it reasonable to argue that this still could be acute hepatitis B, but later on in the infection, after the person cleared the virus? Is that possible? It could, but the only thing arguing against that would be the elevated transaminases. So if his liver function tests were in the 100 range, 200 range, then that would argue that we're seeing this much later in the infection when he could be clearing the virus but still have the IgM antibody. But because he has this elevated transaminases, that does suggest that this is probably not acute hepatitis B, but probably hepatitis A. So let's take a look at one more case with this and see what we've got here. This is a curious case of Mr. Clean. So Mr. Clean was diagnosed with acute hepatitis B at the emergency department, again at our large hospital here in Spokane, St. So-and-so, with the following labs. He had a hepatitis B surface antigen that was positive, Hep B core antibody IgM positive, ALT, right in that sweet spot, and the ratio is good. Bilirubin shows he's a little bit jaundice, so this certainly does look like hepatitis B. Symptoms are compatible. We're seeing GI symptoms with some systemic symptoms in terms of the fatigue, and we've got jaundice. So that all clicks into place. Everything's supporting everything else. Let's take a look at his history. They were initially considering hepatitis A with Mr. Clean because he has no risk factors for hepatitis B. He's in his 50s. He's been married for 27 years. No history of substance abuse or drinking. Works as an accountant. Works and is heavily involved with his church and his grandkids. So he does really look like Mr. Clean. He does look like he doesn't have a lot of risk. So let's kind of take a look at what we're looking at here. With no obvious risk factors, are we looking like we're getting the truth to this? Is there a possibility of kind of a hidden life of substance abuse or marital infidelity? I mean, that's certainly possible. Could it be an acute flare-up of a chronic infection? With his age, if he was having cancer or something like that, that's certainly a possibility. We can't rule that out. Could he have had a medical procedure, and this is maybe a nosocomial infection where he caught this through a procedure? Certainly a possibility with that as well. So we'll look at how do we exclude this. And we do a little bit more history, and here's what we find out. He did have a wayward son who came back home for a period of 6 weeks. His son had been having some problems, moved back to Spokane to kind of get his life sorted out a little bit. Mr. Clean thinks his son had some issues with drinking and using drugs, but he seemed to be clean while he was staying in Spokane. And there didn't appear to be any risk. He wasn't sick. But on later investigation, we had confirmed that his son had a history of injection drug use, but never had any blood work to look at his hepatitis B status. And it was possible that his son had used a shaving razor or toothbrush or other products in the bathroom just because, when he came back home initially, he just came back home with a backpack. So he didn't really come back with that much stuff. So hypothetically, that's certainly possible. He hadn't had any medical procedures during the incubation period, and testing of his wife showed that she was not infected with hepatitis B either. So it could have been a chronic infection that resulted in transmission to the partner. So this case I like because it provides a good reminder of the importance of just any out of ordinary events that may have occurred during the incubation period and kind of looking beyond kind of some of the basic questions that come up on the forms that we have. So these are kind of 3 of our case studies that I wanted to take a look at. I also want to talk about what I call phone a friend situations. These are situations where, we're going to need a little bit additional help. So maybe you have a cluster of cases. Maybe they're related to a possible healthcare exposure. Maybe these are in nursing home residents, where they don't have some of those risk factors, or it could be related to a surgery or a surgical center. If we're seeing something with hepatitis D is a co-infection with hepatitis B. It's an incomplete virus. So for hepatitis B to be able to infect a person, they have to have some kind of active hepatitis B as in boy infection. So because it uses some of the portions of the hepatitis B virus to reproduce itself. So anytime we're looking at things like this, I really want to encourage you to kind of bring other people on board in terms of some help from the state. The state can help with genotyping of cases. When you're looking at relationships between multiple hepatitis B cases where it's not a really easy direct relationship or a household contact or a sexual partner, but that can be very helpful. They can help with the notification piece in terms of public health notifications to providers or notifications to the general public. DOH can also help with other direct assistance. Right now at DOH we have one of their staff is primarily responsible for hepatitis B, whether this is acute infection or perinatal or healthcare associated. So Azumi, someone I've worked with a couple of times, and she's very helpful in terms of taking it to that next level if you do need assistance. One thing I didn't, and I'm going to mention it here, wasn't planning on using it as a case study, but like I said earlier, our incidence rate, what we should be seeing based on the 1 per 100,000 rate that we would see nationally is 4 or 5 cases in Spokane. We've had 4 cases of hepatitis B in the last, I would say, 3 weeks or so, and 3 of the 4 have a history of meth or other substance abuse. One's homeless, and so right now we're in that process of using Department of Health. They're going to be doing some genotyping for us and helping with hepatitis D testing as well, because one of those people was pretty sick. So I'd encourage you to kind of think about using DOH or us as a resource here in Spokane. What I'm going to do now is we have a little bit of extra time. I want to open it up if there's any questions that people have, and see if we can involve all of us together in terms of figuring things out. So everyone's mic should be open at this point. Is there any questions that you guys have for me or of each other in terms of how we're doing things procedure-wise? Anyone want to just test it just so we know that the mic is working?
Hey, Mark, this is Ed out of Lincoln County. I'm just testing.
Works. I'm glad it works. So any questions at all about the presentation or specific aspects of investigating hepatitis B, especially in some of these populations that are a little bit harder to reach? Okay. If we don't have any questions, I'll leave it open for another minute or so. Then we can maybe look at breaking a teeny bit early on this. What I'll be doing is I'll be sending out this presentation out to you via email, and then we'll be posting hopefully within the week this on our YouTube channel so that you could forward other staff to this to take a look at down the road. And then we will also be sending out, we're going to try this time around a survey using kind of SurveyMonkey, maybe making it a little easier and just sending out a link, and people can just fill in an evaluation that way for the presentation and see kind of what aspects of these presentations you're liking the best and how we can serve you guys a little bit better. But any last call for questions at this point? Okay, I want to thank you for tuning into this and helping us kind of make this a really good opportunity for us to share cases in the future and learn from each other. Thank you.